of being joined by Dr. Antonella Moreo from Niguarda Hospital, Cagranda, Milan, Italy, Dr. Gianluca Ponte from Centro Cardiologico Monzino, also Milan, Italy, and Dr. Alessia Ghimelli from the Fondazione Toscana Gabriele Monasterio, also Pisa, Italy. So the aim of this webinar is to give you a better understanding of the role of cardiovascular imaging in COVID patients through clinical cases presentation. When to image, who to image, how to image, but also the required measure of protection. So this session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat, and I will transmit your question to the speakers. And for the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentation. So a very brief introduction from my side. If I can have the next slide, please. Oh, we have a small problem. Yes. So, of course, you know, this is the map of today. You know that we have a lot of patients infected, but also a lot of fatalities. And one of these persons that passed away is our best friend, Maurizio Galderizzi. And so this is some kind of webinar in tribute to his memory. And I think it was important because it's a big loss for the association. So why to discuss about imaging, cardiovascular imaging in COVID? Because first, we know that the major tribute to fatalities in COVID-19 is related to cardiovascular disease, more than 10%. And moreover, if we add to this the risk factors for cardiovascular disease like hypertension, diabetes, we know that the number of fatalities in these patients will be multiplied by 15. Moreover, we know that myocardial injury is related to COVID-19 mortality. We have some publications, recent publications from China, showing that when the patient is ventilated on the left panel end side, so the troponin increase indicate without any overlap that the patient will die compared to the patient that will recover. And it is the same on the right panel end side in patients that are not ventilated. So the troponin, so the myocardial injury somewhere, will predict the outcome in these patients. And this is, of course, a frequent request for imaging. What do we have to do when the troponin are increased? It's a very difficult question that we will try to address because there are different phases in the evolution of the COVID-19, and the origin, the etiology of the myocardial injury can be multifactorial. It could be related to a direct viral attack of the myocardium. It could be due to hypoxia. It could be due to cardiac microvascular damage and spasm, due also to the so-called cytokine storm. So we have not to forget also the issues regarding the protection of course, the healthcare people and let's say the measures that we have to take into account when dealing with this COVID-19 patient, and this will be also addressed during this webinar. So it's time for me to give the hand over to Dr. Ghimelli, and of course this webinar refers to this recent published paper that is in open access in our journal and on the website of the ESC. Alessia, please.
Thank you, Bernard. So I would like to start with the evaluation of this paper, because I think that it's very important for us to see what's happening in the world. And this is very important because the Chinese doctors published this very, very nice and very important paper related to the role of troponin in this kind of pandemic virus and disease. And it's, as you can see, the number of evaluated patients is not very high, even if the rule of cardiovascular implication in terms of fatal outcomes is very important. It doesn't mean that all the patients died for cardiovascular disease, but it's very important because we need to know that we need to manage also the cardiovascular disease in this kind of COVID illness, and we need to be very careful in monitoring this kind of patient in order to avoid all the complications that the cardiovascular disease can do in this patient. And next one, please. Can I? No. Okay, so thank you. And so if you analyze this data, when we analyze the rule of, for example, of the evaluation of troponin in patient with fatal death versus the one that recovered after the COVID disease, we can understand that in this in the patient who died for COVID disease, the increase of troponin was completely different from the ones that recovered completely after the COVID disease. And that's very, very important because it means that in presence of symptomatic patient or in presence of different kind of evaluation of COVID patient, we need to remember that the cardiovascular disease can have an impact. And so we need to manage this patient. How we can manage this patient? So this is the final evaluation of the different impact of the cardiovascular disease in this patient. How we can manage this patient? So for example, we can use the evaluation of troponin, we can use the evaluation of BNP, but we can use also imaging. And which kind of imaging and when can we use imaging in this patient? So the problem is that COVID virus, unfortunately, is very contagious. So we need to be safe, not only in terms of patient, but also versus doctors. So we need to use imaging only when imaging is really appropriate. And when it's really appropriate, when the use of imaging can change the clinical management or can be life-saving versus this kind of patient. And so we need to use only in terms of emergency. So we can postpone, for example, or non-elective patient in order to avoid to spread the virus versus safe patient, safe subject, for example. So we need to be very, very careful in the use of imaging and the use of how to manage different kind of patient. So first of all, the first key point is that we can use imaging, yes, when it's necessary, when it can change the patient management, but we need to avoid the contamination of patient, the infection of other subjects, and the infection of doctors. So this is the key point number 2. We need to be very careful because the risk of infection of professional like not only doctors, but also other personnels, technicians, physicians, it's very important. And also because there is the possibility of the risk of the equipment. So we need to be very, very careful in the post-imaging, in the sense that we need to control that we completely clean all the superfice, we completely clean all the machine that we use it for each patient in order to avoid to spread the virus. So it's very important. And the other important point is that we need to stay with the patient for the minimum time. So we need to avoid to use imaging technique that are longer than effectiveness. So we need to use the best kind of imaging for each patient, but we need to choose the best one also in terms of time. So I would like to show you some cases, and this is the case number 1. So we are speaking about a patient of ICU patient, not ventilated, and this is very important because we need to remember that in front of us we have 4 different kind of patients, but we can speak about it later. In this patient, we have no previous history of cardiovascular disease, but we have a patient positive for COVID. So the COVID is confirmed to the test. And in this kind of patient, we have an increasing of dyspnea with a saturation that is 94% with the oxygen at 8 liters per hour. So there is no pain, no angina, and the HEG is normal. So I would like to ask you what to do in this patient. To evaluate BNP, it could be the best choice, or to use baseline echocardiography, or to monitoring by echo, or to use the echocardiography of the lungs. Why not? The US lungs use, or a CT. What do you do? Can you try to answer, please? You have 1 minute. And if you want, you can send some question also to interact with us, because it's very important, the interaction. We have also 2 very important doctors from Milan, and you know that unfortunately in Italy, the north of Italy is in the worst situation.
Alessia, I received some question here, and I think it would be eventually important to define what is a COVID positive or a COVID suspect patient. We received a lot of questions. How do we define it actually? And some people are asking if it's CT enough, CT plus symptoms, CT plus PCR, or which definition do you use in your hospital to define COVID positive of highly suspect patients?
So as you know, it's a very important point. And so we have 2 possibilities now for the evaluation of COVID patient. The first one is the use of the antibody from the blood. So you can evaluate the presence of IgM or IgG, but it's very simple to do. It's in half an hour now you can have the evaluation of IgG, but unfortunately, in presence of a negative response, is not completely negative, because you can have a situation at the beginning. So you need to do another type of evaluation, also the swab, the lingual swab. And so in this case, you need to wait for 1 day probably, in the best case, in order to have the positive or negative response.
Yeah, so, in my hospital, we use a systematic CT with a scoring system. If the scoring is above a certain threshold, the patient is considered as suspect or positive, especially is symptoms. So people having both symptoms and a CT positive are considered as COVID positive, and we don't wait for the confirmation with PCR actually, but of course if the PCR confirms the diagnosis, the patient is COVID positive. I received in the meanwhile the results of the questions that you asked, because we have to move on. And so interestingly, most of the people think that we should move for a CT thorax, some of them for an echocardiography or an echography of the lungs, 22% for a BNP, and only 10% for echo. So maybe you can move on with your presentation and give what you have done here.
Yes. I would like to focus before answer and before say how we manage this patient. We need to be very careful in the management of the patient. I'm very lucky because I'm working in a place where we can do every kind of imaging, because I'm working in a hospital completely dedicated to cardiac. So we can have echo, we can have a CT, we can have a CMR, so whatever you want. But unfortunately, in some places, it's not very simple to do every kind of imaging, cardiac imaging. So if you have a patient, for example, in the ER room, and so if you don't have the possibility to perform a CT, because sometimes it's happened, so probably you need to do something different. And why not? Echo is very simple to do. It's very fast. And you can use, for example, in presence of pulmonary symptoms, the US lung. And it's really very nice to do. It's very simple. Everyone with a background can do it. And for doing that, I would like to suggest you to share the next webinar that the EACVI will do with Luna Gargani and Atem Soleiman Aboumari. I think next week, and you will have the possibility also to learn something more about the US lung. It could be very important for all of us. And yes, CT probably should be the best choice, because if you are able to manage CT, you can have information not only on the lung disease, but also on the heart disease. So Gianluca probably will explain later how to use it.
Alessia, this patient has a normal ECG, is hospitalized in the ICU, so it's quite difficult to transport. So can you maybe go to what you have done in practice?
Yes,
in this
absolutely. So this is the problem. We can have 4 kinds of patient. So we can have outpatient clinic. We can have hospitalized patient without necessity to have a ventilation. We can have a patient in the ICU, or we can have patient with ventilation in the ICU. So this is from the management point of view, 4 different kind of patients. So all of them can have the same heart disease, but all of them need a different kind of management. So for example, 3 of them can have symptoms. So in presence of symptoms, you can manage this kind of patient with different kind of imaging technique. But in one kind of patient, in the ICU with ventilation, you cannot have symptoms. So in this kind of patient, you need to evaluate with the HEG, probably with the echo. It's the only one thing that you can do. And at the last one, the use of coronary angiography. But you cannot do, for example, a CT in this kind of patients, or probably it could be not so simple to do in a normal hospital, in a not dedicated cardiac hospital, in the last kind of patient. But
in these patients, we had some increase in dyspnea.
Yes.
So if we look at your algorithm here, so we have an aggravation of the heart failure.
Yes.
And so it's recommended in our paper to go for BNP evaluation. Maybe you can give the results of the BNP before we discuss further on.
Very low BNP. So in this kind of patient, apparently, there is no need for echo, and we can have the evaluation with lung echocardiography. Why not? Because we can have the information about the lung with a very nice and simple way. And this is the imaging of the US lung. It's very nice because you can see that there is the B line and the pulmonary consolidation. And it's typical for the COVID patient. In COVID patient, this is a very, very typical US pattern. So it's completely different from the one that you have in patient with heart failure, for example. It's completely different from other kind of patient, but it's very typical for COVID patients. So it's you can do in 3 minutes, 4 minutes. It's very simple to do, and so could be very effective for this kind of evaluation. But for example, you can have another kind of patient. This is an ICU patient, not ventilated, but here you have history of cardiovascular disease in a chronic follow-up for heart failure. Also in this patient, we have COVID confirmed. And like in the previous one, you have an increase of dyspnea without angina, and the HEG is normal. So accordingly to the other question, what we can do in this kind of patient? We can have the evaluation of BNP. We can do an echo. We can monitor him by echo. We can have an echo of the lungs or a CT. What do you suggest to do?
Okay.
Probably Gianluca answered.
I received a lot of questions in the meanwhile. So some people are asking why we can use a CT in all suspect COVID-19 patients. How can we justify the radiation? So it's a very low radiation CT, and I think it's the best way to screen the patient. You have the results immediately. So we have the results already of the questions, and the majority are proposing to have a CT thorax. So maybe you can move on. The second option is BNP. It's still.
Yes. This is
maybe you can comment on that.
Yes, and the BNP is very high, more than 4,000. So we perform an echo, and then we perform also the lung ultrasound. And also in this case, you can see that there is B lines, coalescent B lines with subpleural alteration. And also in this case, it's very typical. So we use CT, but I would like to spread the message that in some cases, and when you cannot have the possibility to do the CT, you can use also the US lung, because it's very simple to do. You can have lots of information, and you can do without disseminate the virus in other, for example, in other rooms, in other buildings. If you cannot have the possibility to perform a CT in the same building or very close to the patient. And so it's very, very nice way to have information about this kind of patient.
In this case, the BNP was also elevated, so the echo was also indicated then.
Yes, it's indicated, but the type of evaluation of US lung is completely different from heart failure. So the coalescence of the B lines is typical for the COVID. So you cannot see the B line like in the heart failure patient, because it's completely different pattern. It's very typical for COVID.
Okay.
So when you do an echo, remember, you need to remember that you avoid to be infected by the virus. So you need to perform an evaluation at a minimum. So you need to have the evaluation of ejection fraction, of possible sign of regional dysfunction, and diastolic cavity dimension. So you cannot have the thickening of the septum or something like that. You need to use only very few kind of variables, but the ones that can help you to manage the patient and to change the treatment of the patient if necessary. Also for the right ventricle, global function, or the evaluation of the tricuspid valve, the end diastolic cavity dimension, and only if possible, the use of tricuspid regurgitation gradient. And also for the valves, you need to avoid to use all the variables that you can do, but you need to evaluate the presence of insufficiency or presence of gross signs of valvular disease. And for pericardium, that's very important, presence of thickening or effusion. So it's not an evaluation, a complete evaluation, but it's mandatory to have a minimal evaluation. what are the indications for other echo methods? You can do, for example, stress in patients with suspected COVID. Probably yes, but only when it's necessary. You can do only in patients, for example, in outpatient clinic where there is a change in symptoms and so on. CT angiography should be preferred because you can do also the evaluation of COVID, presence of COVID disease, and also ultrasonic contrast agent may be used, but not as the first choice. And
I can interrupt you 2 seconds, and we can come back to this slide. So I received a lot of questions regarding this.
Yes.
So some people are suggesting that why not to go directly for CT, for coronary angiography if you have a suspicion of coronary artery disease, if there is some symptoms or the ECG is suggestive. That's for first. Second, we have also some questions regarding the use of contrast. Some people are quite frustrated that they cannot use contrast following the recommendation. I think we should maybe comment on that and saying that actually we know that there are some reassuring publications regarding the use of contrast agents in critically ill patients, but we have no experience in COVID-19, and especially in patients with ARDS. So in these patients, we should not recommend to use it. You can eventually use it, but only in case of difficult to image thrombus or so on, but not I think in the patients that are ventilated with an RDS. It's not recommended. Imagine that these patients may have complications related to the contrast injection. I think it could be a big issue to manage. And second, in other patients, it means that this will prolong the examination by the need to put a line and to inject the contrast. So that's why it's not in the recommendation. Maybe for the angiography, you can comment on that. And the use of CT angio, maybe can also Gianluca comment on that.
I think that Gianluca can comment better than us the use of CT. Regarding coronary angio, yes, I agree that in some kind of patient probably should be better to go directly to the cath lab. But we need to be sure that we have a dedicated cath lab, because otherwise it's a problem. So the problem is that we need to have a distinct process for COVID patient and not COVID patients. So in presence, for example, of two different kind of cath lab, one dedicated to COVID and one dedicated to no COVID patient, you can do it very, very simple. But in absence of it, it's a mess. It's really a mess. So probably in some cases it should be better to use coronary angiography only in dedicated cases. Also because sometimes, and I think that Gianluca will help us to understand better how to manage this situation. We have lots of Minoka. And so we need to remember that the use of coronary angiography, it's useful only when we can change the management of this patient. But how do we be sure that in presence of Minoka we change it? So we need to understand which kind of patient should be submitted to invasive coronary angiography. So,
okay, we have to speed up a little bit because we are late, as you know.
2 minutes. 2 minutes to remember that you need to be safe. So you need to use protection. You can use different kind of protection in presence of different kind of risk. So you can read it in our manuscript. I don't want to stress it. I think that all of us are very stressed about the use of protection. So please stay safe. It's the only thing that I would like to stress. Only 2 slides in order to remember that we are not the only societies that are stressed the use of imaging in dedicated patient, to stress the rule of imaging in this kind of disease, but all of the association agree that we need to use imaging only in presence of patient where imaging can change the management. So it's the same for the American Society of Nuclear Cardiology, and it's the same also for the Society of Cardiac CT. All the societies agree that imaging, yes, but only in a subgroup of dedicated patients. So you can read it. Thank you.
Crystal clear. Thank you so much, Alessia. So I give now the handover Antonella. Antonella, please.
Good evening to everybody. Since the end of February, when the Lombardy became the epicenter of coronavirus epidemic, all the public and the private hospital of the region were involved in this health emergency. For this reason, all non-urgent surgical procedure and all the scheduled hospitalization were postponed to devolve all the effort in the management of this emergency. Obviously, this has an impact in the Eco Lab, and you see which was the difference between the examination that we perform in the March 2019 versus the examination that we perform in this year. And this decrease was particularly important for outpatients. For the outpatients. When the next slide, and the emergency in March became more important, and for this reason, all the examination, the ambulatory visit were stopped, and you see the decrease, the important decrease in the examination for outpatients, because we focus our work only with the patients that cannot postpone the examination. This means patients where we have to monitoring cardiotoxicity during the chemotherapy, or the patients that need urgent echocardiography. And also the indication for perform the echocardiography study, you see where heart failure, where the evaluation of patients with cardiac and liver transplant, or patients that arrive in the hospital with a neurological problem, because with an increase in this indication, because we became hub for all stroke and neurosurgical problem. And I will start my presentation of this case that is a 54 years old male that was admitted to our emergency department for a neurological problem. He performed a CT scan, and this examination revealed ischemia area in the frontal lobe, right frontal lobe, and left parietal lobe. At this time, the patient performed also an ECG, and we see an important alteration of this ECG. And when we ask to the sister of the patient, if he has a previous history of cardiac history, she said that he has not the previous cardiac problem, but in the week before the admission, he has some abdominal pain, but he was very afraid about to come to the hospital. Now, what we can do in these patients? In your opinion, which could be the best examination that we have to perform? We have to do a transesophageal echocardiography, a transthoracic echocardiography. On the basis of the ECG, we go directly to a coronary angiography. We have to perform echocardiography of the lung to see if there is any pulmonic problem, or we have to screen if there is a COVID problem, a pneumonia, performing CT thorax.
So the great majority answering that we have to proceed to a transthoracic echo, Antonella.
Okay, I think that this was what we do, and we see some things very interesting, because you see a very important depression of the left ventricle. There is some echo contrast, but we see also the presence of pericardial effusion with some very typical aspect of hematic pericardial effusion. We have some sign of compression of the right side. And when we focus our attention of the lateral, infralateral wall, we see this very typical aspect that is suggesting for a laceration of the wall, with some things that is moving, that could be some muscle of the, or some thrombus we cannot say in these images. Now, what we can do? Okay, what we can do? On the basis of these echocardiographic findings, we suppose that we was a rupture of the lateral wall in patients with infarction, and we perform coronary angiography, and you see very well the stop of this marginal vessel. And after discussion with in our team with the neurologist and surgeon, we decided to perform surgery, and we clearly see at the surgery the presence of laceration of the lateral wall. The patients, we put a patch in this region, he performed a bypass, and now is in 7 days after surgery, and he has some neurological reliquate, but is now is well. This case gives us the opportunity to discuss about the initiation of transesophageal echocardiography. In this case, we don't have any information, adjunctive information because we have only what we need to decide the right treatment of this patient by transthoracic echocardiography. Transesophageal echocardiography is examination that has a high risk of contamination for the doctors, for the nurses, but also give us some problem also for the equipment, because during the examination there are droplets and aerosol with virus. In this case, we cannot know if the patient was positive, but usually we have to pay a lot of attention because there are a lot of symptomatic patients. And I think that as already Alessia underlined, that all the procedures imaging are to be performed only if they can give us information that can change the guide of the treatment, for the treatment. This is another case. Is a patient that was admitted to the intensive care unit, a COVID intensive care unit, and he has, after 7 days, he developed a sepsis. And the blood culture, there was a Streptococcus hominis, and for this reason, the anesthesiologist asked us examination, and they asked to perform the examination also because the patient developed hemodynamic instability. What do we do in your opinion? We perform a echocardiography, a BNP evaluation, a CT angiography. We go directly to a transesophageal echocardiography because there is the suspicion of endocarditis or other examination.
So waiting for the answers of the attendees, we received a lot of questions regarding the treatment of COVID-19 patients. I think this is not the place to address this issue. And second, we received a lot of questions regarding the incidences of myocarditis. I think there is a dedicated presentation available on the EACVI website addressing that. We will talk about it, but not in a very extended manner. So we have the results, Antonella. So we have 71% saying that we should proceed to echo. Please, move on.
Okay, was what we did, and we have in this patient is a patient with a mechanical ventilation. The image is transthoracic. The view is not very good, but if we look at the parasternal view, we can see a huge right ventricle, and this is confirmed also in the subcostal view. Now, the patient has an important right involvement, but is a patient with a ventilation, with high positive pressure of the ventilation, and also he has a COVID pneumonia. And now what we have to do, in your opinion? We decide to perform a CT scan, and CT scan confirm the big enlargement of the right ventricle, but we saw also this very big thrombus in the pulmonary arteries, and this instability, hemodynamic instability, was due to a pulmonary embolism. And this is an important aspect that we have to take in account in this kind of patients, because the prolonged immobilization, the vascular inflammation that can increase, can determine a hypercoagulable state and an endothelial dysfunction, can be at the basis of this complication. It's important to remember that also the therapy, the non-invasive therapy with the helmet can produce some stasis, venous stasis, because the helmet in some cases is fixed by this arm, and this can cause thrombus, like what happened in this case.
Yes, indeed. I think we see that the thrombogenicity in these patients is very high, not only at the level of the venous side, but also at the level of the arterial side. So this is quite frequent to see patients with DVTs and with pulmonary embolism indeed. So because of sake of time, we need to move on now to the next presentation, and it's my pleasure to invite Gianluca to give a very quick and nice presentation on the role of CT, illustrated by very nice cases. Gianluca.
Thank you very much, Bernard, first of all, for this kind invitation. Let me just start with the clinical case, just to use this case as point of discussion regarding to the use and the role of CT, computed tomography, in the patient with COVID-19 infection. This is an history of a 60 years old male patient with an history of hypertension, who was referred to an hospital for chest pain during hypertensive crisis. The EACG was a bit equivocal because we don't find significant changes, but of course we want to underline the presence of small negative inferior T waves and no abnormal findings at echocardiography. Of course, the patient, for the patient was tested the presence of increase of high sensitive troponin I, and it was normal as well. I want just to show you the EKG and to share with you the EKG. The quality of the image is not so good, but as you can see here, there is a clear evidence of negative T waves in inferior leads. And there was no previous EKG of the patient available just to have a comparison. So we need to consider this a potential indirect sign of myocardial ischemia. However, considering the absence of increase of troponin I and characteristics of the chest pain, the patient was discharged, and the reference physician suggested to the functional stress test in this patient. According to this suggestion, the patient was referred to another hospital to perform an exercise ECG, who was equivocal. Just to save time, we go directly to the conclusion of this exercise ECG, and as you can see here, we found just a pseudo-normalization of the inferior T waves. So this is a typical submaximal exercise ECG with equivocal findings, so not clear diagnosis. But about a couple of minutes after the end of the exercise ECG, the patient had again a new onset of chest pain, and an exercise ECG was done during the symptoms, during the chest pain, and as you can see here, a very mild increase, a very mild ST elevation was observed in leads V2 and V3. Is not very clear because it's just a mild ST elevation, and unfortunately I don't have in this picture, but there was no specularity in inferior leads. So it could be an acute coronary syndrome, but this is not totally clear. In this case, the patient, after this EKG, and again, the high sensitivity troponin was tested in this patient. And as you can see here, in this case, we found an increase of the value with a peak value and then a slow decrease of the high sensitivity troponin I with a plateau value at the end of the observation. So the chest X-ray that was performed was negative. I just want to underline that this patient was referred during the COVID-19 pandemic, and this is a good reason to screen this patient with chest X-ray as well, and was classified as negative for pneumonia. So at the moment, what we have to do in this patient? Medical therapy, and then to refer the patient for a further stress imaging test because we consider the setting still not clear. We can suggest, for example, a cardiac computed tomography because we need to rule out, for example, coronary artery disease here. We can classify this patient as having an acute coronary syndrome with ST elevation, so direct access to invasive coronary angiography, or a very total conservative approach considering the COVID-19 pandemic, just medical therapy with no additional test. This is just a test to evaluate your opinion because there is not a right answer. So please share your opinion.
Minoka, I have a question. Is that reasonable to perform a stress test in a COVID patient? I know it was done in another hospital, but nevertheless, I think it's...
Yeah, okay. Theoretically, if we are outside of COVID-19, you could do. At the moment, for example, in our region, there is a very restrictive access to perform this kind of test. So at the moment, we strongly are discouraging this kind of approach for mainly for logistic reason, because we are really totally manage urgent patient and not elective patient.
Okay, we have the results of the questionnaire. So we have the majority of attendees voting for a cardiac computed tomography. Maybe they are biased, but also a lot of attendees are voting for invasive coronary angiography. Maybe you can discuss the advantage of one method against the other, because this is also part of the numerous questions that I received actually.
Yeah, that is a very important point. Of course, despite there is the COVID-19 pandemic, the rules are always the same regarding to which is the best test in terms of diagnosis. So everything is depends on the idea that you have in your mind of this patient about the probability to have a true acute coronary syndrome. Because if you believe that this patient has disease, of course, we need to minimize any kind of non-necessary test. So we can decide to refer the patient directly to cath lab because we want to treat this patient. But if in your mind you have the suspicion that there is no coronary artery disease, of course, to rule out the presence of acute coronary syndrome with CT could be reasonable. So it depends exactly what you believe this patient has before to select the test. So I go ahead and the decision of the reference physician was, I can just skip this one, was to go to the invasive coronary angiography. And to the invasive coronary angiography. And which is the reason? Because the reference physician classified this patient as a potential acute coronary syndrome with ST elevation of myocardial infarction. We have a troponin increase, mild ST elevation, chest pain, of course. So we need to consider all these characteristics as well. Anyway, behind this aspect, to do a cath lab is not so easy during COVID-19 pandemic, because the majority of hospitals in Lombardy, for example, were totally reorganized in terms of COVID-19 management. And a lot of the cath lab of this hospital were closed because for the risk of infection, and they were totally focused on COVID-19 infection. So for this reason, Lombardy region set up a reorganization of the model, creating a sort of hub-spokes model in which there are some hospitals fully dedicated for COVID-19 infection, and other hospitals are totally focused to manage cardiovascular urgent indication. In this hub-spokes model, our hospital, Centro Cardiologico Monzino, considering that is an heart institute, so totally dedicated for cardiovascular disease, was selected as a hub for cardiovascular indication, keeping the number of patients with COVID-19 infection as lowest as possible inside the hospital to keep the hospital clean and open for any kind of urgent cardiac disease. So the patient was referred to our attention with indication for the cath lab, and we refer the patient according to the suggestion to the cath lab. This is exactly our workflow, our model, organizative model in our practice. When you have a patient who is referred from another hospital with suspected acute coronary syndrome, we can imagine to have 3 different scenarios. The first scenario is a patient with ST elevation myocardial infarction. The second scenario is a patient with non-ST myocardial infarction in unstable condition. And the third scenario is patient with a non-ST elevation myocardial infarction with stable scenario. In the first 2 cases, of course, we need to not forget that time is muscle, and in case there is a true acute coronary syndrome, we need to treat and to revascularize the patient. So in this case, what do? We do immediately the oropharyngeal swab, and then we send the material for the analysis, and then we start with invasive coronary angiography to check the disease and eventually to treat. In case of a patient with non-ST elevation myocardial infarction who are stable, we prefer to treat in the first step with medical therapy, to do the oropharyngeal swab, and then to wait the result of the check of the swab. Okay. In this case, the patient was classified as ST elevation myocardial infarction. So we did the oropharyngeal swab, and then we referred the patient for the cath lab. And this was exactly what we found in the cath lab. Right coronary artery. I hope that the moves works well. Okay. Left coronary artery is here. And this is left coronary artery in another projection. In other words, there was no coronary artery stenosis, no obstructive coronary artery stenosis. So, technically, this is a Minoka. We have an increase of enzyme. We have chest pain. We have no obstructive coronary artery disease. While we were finishing the procedure, we received the result of a pharyngeal swab that was positive. So this was a COVID-19 patient with chest pain, dyspnea, and suspected acute coronary syndrome. After cath lab, the diagnosis was Minoka. So, I want just to remember briefly the definition of Minoka, the presence of acute myocardial infarction according to the official definition. Second point is the evidence of non-obstructive coronary artery disease. The third point is to have no alternative diagnosis. Usually I don't like so much the word Minoka because I prefer to use the word of Thromboembolic for a simple reason. In this phase, we don't still know the diagnosis. We have increase of troponin and no obstructive coronary artery disease. If you use the word of Minoka, you are stating that there is myocardial infarction, but we don't know if there is myocardial infarction or real. So I believe that it's more correct to use this word. What do we have to do in this case? Okay, look at this patient. This is a patient swab positive with Minoka or Thromboembolic, as you prefer. In this case, we refer the patient in dedicated area of the intensive care unit where we locate the patient with infection. And after this step, we need to decide what to do in this patient. So the patient is isolated. We have a diagnosis of Thromboembolic or Minoka, and we have to do how to go ahead. Medical therapy, cardiac magnetic resonance, cardiac computed tomography, I don't know. My favorite answer is I don't know. I don't know is the best choice.
It's easy. But so in the meanwhile, we have received a massive amount of questions regarding myocarditis. As I mentioned earlier, there is a specific lecture available on the EACVI website on that topic. And maybe you will address that very shortly afterwards, Gianluca, and the indication of CMR in that perspective. Just to remind you that, Of course, to go for CMR, it means that you need to have a dedicated machine.
Yeah.
That the transportation of the patient is also important in terms of contamination, and the duration of the procedure is also something that we have to take into account in terms of contamination. So you have really to weigh the benefit and the risk ratio in these patients regarding myocarditis. And to summarize a little bit, so it's not clear how much we have many myocarditis in these patients. But please refer to this lecture. And the other point is that we receive still a lot of questions regarding the protection procedures. So this is clearly stated in the recommendation paper. So it was already addressed by Alessia before, but if you need some more information, do not hesitate to go to the paper. It's very clear, and you can read the paper after the webinar if you want. So the response is CMR in that as the most frequent examination proposed by the attendees.
Okay, the cardiac magnetic resonance is for sure the best option, because everybody knows very well the role of CMR in Minoka, for a very simple reason. Because in Minoka, if you scan the patient with the CMR, you are able to differentiate between the different scenarios, such as myocarditis, Takotsubo syndrome, still myocardial infarction, because you can have a myocardial infarction with no coronary artery disease. And this is just an example of two registry in which all these entities were really well detected by cardiac magnetic resonance. No doubt that this is a very robust indication, and these are just some examples. The first one, Takotsubo cardiomyopathy, CMR has edema, huge edema with no late gathering enhancement. The second one is myocarditis, in which you have edema and you have a non-ischemic late GAD pattern. The third one is myocardial infarction, despite you have no coronary artery stenosis. Here you can see typical focal myocardial scar related to probably embolism or something or similar, or you can also find a normal CMR. To do this kind of differential diagnosis is very important, because based on your diagnosis, the outcome is completely different. And I want also to add that the management and therapeutic management of a patient is completely different. But this is just a statement from our document of the EACVI. And one of the suggestions that we include in this document is the following one. An important strategy to reduce contamination is to reserve one scanner for non-infected patient and another for low risk and non-infected patient, if of course you have this kind of logistics solution. In our department, we have one MR and two CT. And so we have one CT dedicated for infected, one for clean patient, and for CMR is a bit complicated because we don't have an additional scanner. This is important because, of course, we have a lot of concern regarding to the cleaning of machine, and also the management of the patient inside the machine, because as you know, the exam is very long, about 1 hour. And so the risk of environment contamination in 1 hour is not like in other imaging modality, which in 10 minutes to 15 minutes, we have finished to evaluate the patient. So we are here in this position. What to do if you cannot do MR for this reason? One observation that we had in our hospital, this evidence needs to be confirmed by other experience, is that we observe a huge increase of Minoka as compared to the same period of the last year. We don't still know if behind this Minoka there are myocarditis or not. There is no still numbers on that, but there is a suspicion that probably COVID-19 could play a role in this increase of Minoka in the Lombardy region. So according to about all this point, we have decided to refer the patient to cardiac CT. Because if you modify the protocol of cardiac CT, you can give answer to multiple questions in COVID-19 patient. First of all, if there is a lung involvement, if there is pneumonia. Second, if there is pulmonary embolism, because we know that this kind of finding is associated with COVID-19 infection. Third point, if there is subclinical atherosclerosis in case of Minoka, like this case. But last but not least, to add information about the myocardial texture to rule out myocarditis. Despite there is no still indication, robust indication for CT on that, there are some preliminary experience like this one published by the group of Antonio Esposito of San Rafael Hospital that you can do. You can image late enhancement of myocardium with cardiac CT, mimicking what is the job of cardiac MR. And this is our patient. We did chest CT, and as you can see here, we found some ground glass pattern suggesting an early stage of COVID-19 pneumonia. Of course, we look at the coronary arteries again. There is no subclinical atherosclerosis, and there was no pulmonary embolism. I don't have the picture here, but was negative for pulmonary embolism. But then we had the further late enhancement acquisition 7 minutes after the injection of a contrast agent, and this was the result. This is the arterial dataset, I mean the dataset that we use for coronary arteries, and this is the late enhancement acquisition with CT. And as you can see here in inferolateral wall, you can observe a non-ischemic late enhancement pattern suggesting the presence of myocarditis in that region. This is the same images in long axis 3-chamber view here, and this is the same images with a different color scale just to highlight the presence of myocarditis in this region. So the message is that we can use as alternative CT if you have the right technology, the right experience, and in case you are in a condition in which you cannot perform cardiac MR. Because the CT is able to do a sort of quadruple rule out. This is just my main messages about my case. Increase of high sensitivity troponin I is a common finding for COVID-19 infection. You should have a specific non-invasive and invasive route for the patient to separate infected versus non-infected. We are observing an increase of Minoka, and this is a very relevant dilemma in the management of this patient. When you select your imaging modality, you need to keep in mind all concerns related to the cleaning and disinfection of the equipment, and cardiac CT in some specific cases and setting could be a very practical tool to do the quadruple rule out to identify the presence of pneumonia, coronary artery disease, pulmonary embolism, and myocarditis in case. Thank you, Bernard.
Thank you, Gianluca. So we have also received a question, a very tricky question. How much does imaging, diagnosing, so as you have shown, a myocarditis can change the management of the patient?
In acute phase, to be honest, probably don't change in this specific case because we don't have, I don't know, left ventricle dysfunction or any kind of other urgent situation. Of course, if you have a patient with myocarditis and left ventricle dysfunction, the identification of myocarditis and potentially the use of biopsy to identify the reason of myocarditis could be theoretically useful to apply a specific therapy of the patient. Of course, in this case, you can decide to refer the patient to CMR in the after the end of the acute phase is one of the options in case, but considering that here you have to do CT for pulmonary embolism, for chest CT, and you have to inject contrast agent for this reason, it's very simple to wait 5 minutes and to do a second picture by using the same contrast agent that you have used. So you can add the further information without any kind of true additional test. Just a bit of radiation more, but do not forget that the mean exposure of this kind of scanner is 2 millisievert for each scan. So it's extremely, extremely competitive.
Yeah, very interesting indeed. I think that, of course, there are some trials ongoing regarding the treatment of what I call myocardial injury. I think it's a more general term to say that there is some myocardial damage, because indeed the elevation of the troponin, as I mentioned in the beginning, can be multifactorial. And at the end of the disease, when we are in this cytokine storm, we know that there are some potential treatment like inhibitors of interleukin and so on that can be given if we have, of course, documented some myocardial damage. But usually this is given also to treat the pulmonary problem, which is probably the main concerns actually. And so it can be useful. So we don't necessarily need to document this myocarditis, but I completely agree with you. This means that this kind of patient should be followed up and of course also monitorized if not already the case, because the risk of having some arrhythmias within the first 48 hours is very important. So I think it's time to conclude, and maybe we'll take the hand over again for the take-home messages. I know that you'll be a little bit frustrated because we received a lot of questions. Many questions were not in relation with the imaging and COVID, mainly on treatment, on management, on the way to make the diagnosis. Nevertheless, the question that was not addressed today may be eventually sent to our experts, and they will answer offline to these questions. So the take-home messages are clearly that cardiac imaging should be performed if appropriate, and only if it's likely to substantially change patient management and be life-saving. So use the best modality with the best capability. I think we have a nice demonstration here with the last case. You have a lot of information, but also consider the safety for the medical staff regarding exposure. This is a priority. This is why we are not applying, for example, systematic echocardiography in all the COVID patients. So the prolonged duration of cardiac imaging study or the need for transportation should also be taken into account, because this will increase the likelihood of contamination. And the next slide is, of course, that we face a different range of different cardiovascular manifestation. And we have also, depending on the manifestation, symptoms, no symptoms, increase of troponin, eventually dyspnea, arrhythmias. We have, of course, to cope with all these symptoms and to choose the best cardiac imaging modality. So finally, the risk of contamination of equipment and personnel is very high during transesophageal echo, and therefore we have to consider alternative techniques. And coronary CT angiography can be used to exclude or confirm acute coronary syndromes in COVID-19 patients where elevated troponins are not uncommon. And as mentioned in the last talk by Gianluca, prepare the post-pandemic era, reconvene your patients in several months to control them, because we know from influenza infection and pandemia that these patients will have much more complications, cardiovascular complications in the next following months than lung complications. So thank you for attention. Do not forget that there will be also next week a webinar on lung ultrasound in COVID patients. There is online, so a lecture on myocarditis. The recommendation paper is available online with all the recommendations. And so please enjoy these documents. Thank you for attention. I want also to thank, of course, Dr. Ghimeli, Dr. Pontone, and Moreo for their excellent presentation. Thank you very much indeed, and see you later. Bye-bye.
Bye-bye.
Thank you. Bye.